All right, Dan, what do you think of this?
31-year-old male with sports injury 2 hours before an MRI. With sensitive. Can I see more images, please? I'm not sure I see much. There's some fluid signal, superficial. You're showing me something there, which might be some type of expulsion, but I'm not sure.
What are these?
Those are the ribs.
Okay, so what do you think this might be?
Oh, that could be quadratus lumborum. All right. Quadratus lumborum.
Here are the sagittal images.
Oh, transverse ab.
Yeah, so this is an intercostal muscle tear, right. So that's one form of trauma in this area that you might see on an MRI of the lumbar spine.
46-year-old female, 4 months back pain after strain injury.
Degenerative disease down here.
Yeah. We're looking in the the posterior muscles there. Is there some edema? Yeah, in the rector spinae muscles, maybe a muscle strain.
Right. And here we can see on either side the edema within the spinae erector muscles there. And that's all longissumus strain. So you have to remember muscle strains.
All right. 27-year-old man, symptoms compatible with sciatic neuropathy.
John, can you hear Tayson?
Yes.
Good.
Following drug overdose. Prolonged witness coma in supine position.
Coma.
Coma.
Let me spell it.
So we're looking at the sciatic nerve there.
Okay, right in here. That's where it goes, just posterior to the hip joint there. And there you can see the two sides using
it's like
T2
there's some increased signal asymmetrically on the right.
Okay. And maybe looks like maybe a little bit bigger on the right.
Yeah.
Oops. Anyway. Yeah. Anyway, this was a sciatic neuropathy due to being in one position too long and too much pressure on the sciatic nerve.
Yeah, it looked like one was first.
Okay, Robert.
All right, so we have a 58-year-old female, lower back pain, 10-year medication history for lower back pain at a local clinic. And, here, posterior elements, there's a lot of, what looks like just stroke calcifications there. I'd like to see either a CT or MRI.
Yeah, a lot of other calcifications too. So there's your CT.
Yeah, it looks like there's a lot of dystrophic calcifications within the spinal canal. It looks like it results in pretty severe stenosis.
Okay, okay. So you think this is?
Was that a myelogram? Old one?
No, this is just a straight CT. This is all calcium, John. This is all this calcium deposits in around where they injected.
I have a feeling they injected it. I don't know why.
Yeah. And here we can see all this dystrophic calcifications in the soft tissues, producing central stenosis. So this was their differential diagnosis here. So they went in. What do you think here, Robert?
All right, so it looks like they did some laminectomies.
Yeah, to clean that out and get rid of the stenosis. So they did biopsy.
That's quite a long incision there.
Yeah. So worried about instability. So that's what they ended up finding is that there were parasite eggs And these areas of calcification are really ossification within the soft tissues, no evidence of malignancy and some chronic inflammatory disease. And this is just another case where you can, so that one was due to a parasite infestation. Here's another case where you can see calcification in the space there. This one was, okay, and then here's one that's due to thought to be due to steroid injections, repetitive steroid injections. Okay. See, Daniel.
61-year-old female, pain at the lumbosacral junction after a long flight. So, some taint or stirs. Axial views at the level of sacral junction.
Because that other one should be an infectious disease.
It's like there's, yeah, I just don't know how to really describe that. Increased signal on the right side of the, like, extradural, I think.
So you think this is extradural?
You think is it intra?
Okay, let's think about that. Look at the way the nerve roots are clumped back here.
Oh,
And look at the configuration of this stuff. So this is, what is it? So this is a hemorrhage, right?
okay.
Okay. And then if we can look, enhancement, there's really, again, we don't have pre and post, so we don't know whether there's enhancement or not. There are the sagittal images. What do you see here?
So it's intradural. Looks like there's,
So again, it looks like there are a lot of inhomogeneous signal intensity, maybe some clumping of the nerve roots that are coming down. Again, with all this different signal intensity, you have to worry about blood products.
okay.
But not a lot of enhancement here.
Was there a little anterior diastasis on one level there at 3-4, I think?
And here, there's a little spondylolisthesis here.
Yeah.
Yeah.
And then at 5S1, maybe there's
So this is
retrolastasis. I'm not sure.
yeah, that's long fine.
What's your opinion, John?
Yeah, well, I think is what we're seeing here is hemorrhage into the spine. The question is, what space is it in? And this was spontaneous subdural hemorrhage. So what are the kinds of hemorrhages you can get in the spine?
It does look like retrolastatic.
Like,
5S1.
So the four types to distinguish are epidural, subdural, subarachnoid, and intramedullary. And sometimes it's a little difficult to differentiate the two. But if you remember the anatomy here, you've got the dural on the outside here. Then inside the dural, you have the subdural space. And then you have the covering of the arachnoid here. And inside that, you've got the subarachnoid space, which is the blue that we're seeing here. And then inside of that, you actually have the coverings of the nerve roots and the cord itself. And then inside of that, you have the intermedullary hemorrhage. Okay, so with subdural hemorrhages, you tend to get a kind of a funny appearance. In the axial plane, you'll often see the nerve roots in the lumbar spine being this kind of Mercedes sign with blood and the three compartments. It has variations, but it kind of looks a little bit like this. I'll show you some better examples in a minute. Let's see. Let me see. Elio?
74-year-old man, back pain. on the T1 image on the left, we see increased signal. Looks like, I mean, yeah, it could be in the epidural space there.
Okay. And
It's
here we
right
can
on
see it on the T2, and here's the stir. Here's probably post-contrast in one.
Hematomic.
And this turned out to be a subdural hematoma.
Okay.
Okay, so
All right.
Mason,
Both leg posterior aspect radiating pain. Well, it's like this spinal cord has that Mercedes-Benz type of look to it that we
Yeah.
just talked about. So
yeah.
another subdural.
So this is another subdural. This was a chronic subdural. Good. Robert. So this patient had multi-epidural injections.
All right. So we have chronic back pain that is post multiple epidural injections. Let's see. Looks like on the axial images, there may be some increased signal surrounding the spinal cord there.
Yeah. And so if you look back at the diagram that we had,
Mhm.
this fluid, which is abnormal, looks like it's outside of all of those layers. So this is a typical epidural space fluid collection. And if you notice here, it's relatively free flowing up and down, not contained like the subdural ones that we saw. So there's more free flow in the epidural space. And again, you can see that it's external to the dural layers here.
Yeah.
So this is a typical epidural hematoma. And down in the lumbar area, it can be a little bit difficult sometimes, but you can clearly see that there's abnormal fluid around the cord up in the thoracic area. Okay? And then,
Did they give you any symptoms at all in terms of is it numbness or pain or what?
just chronic back pain.
Chronic back pain? That's
Not treated well by epidural injection.
I've never seen a case.
Yeah, that was from Denver, Colorado. Okay, now let's talk about acute spine injuries. And there is a classification system that's been published. And if you're in a hospital or a trauma center, a high-level trauma center, I think this is one that's relatively commonly used. We really, in the outpatient setting like we have, we don't see this kind of trauma. It really goes to hospital emergency rooms. But I'm just kind of going to go through this category because I think it's just kind of worthwhile for you to know. And for those of you who are going to be involved in trauma centers, you just have to check and see what kind of a grading system they like to use to make clinical decisions. And it may be something similar to this, or it may be this one. So you can look at the image morphology, whether it's a compression fracture, a burst fracture, translational rotation, and distraction. And each of these are progressively worse and get progressively higher numbers. PLC strain, you can look and see whether it's intact. We'll go through these in a minute. Whether it's injured or whether it's definitely injured, and then you get different numbers there. And then the neurologic status, intact, nerve root symptoms, spinal cord or cornus medullaris type injury, incomplete or complete, and then the cauda-equina syndrome. So, and then each of these are numbers, and you add them up, as I'll show in a minute, and that can help determine whether you need surgery or not based upon this particular paper. So let's talk a little bit about how forces are transmitted through the vertebral body. You can kind of divide the force transmission into the anterior column and the posterior column. And kind of in between are the pedicles bridging the two together. The anterior column is really the discs and the vertebral bodies. And then the posterior columns are really the spinous processes, the interspinous ligament and the posterior longitudinal ligament back here. And it kind of works a little bit like a crane works. The forces predominantly go down to the floor through the vertebral bodies, but then you have to have firing of the spinae erecti muscles here to maintain the proper position of the spine during different activities. And there's a lot more strain on these posterior elements when you're bent over forward, which is an area where you can get, especially older individuals, can end up getting injuries to the spine. And then the straight upright position, you can see the forces go right down through the vertebral bodies with less incidence of translational forces. So let's talk about some of the different kind of fractures. This is from radiographics. You can get a straight compression fracture here, where you can see the compression of the vertebral body, and that would be a straight. The posterior and the anterior cortices are relatively well maintained, and you just have impaction of either one or both of the end plates on either side. These are generally stable lesions. Then number two is a burst fracture, where you have all these multiple fragments within the vertebral body. And here you typically will get compression of the posterior and or anterior cortices. As we're seeing here, this extends out to involve the cortex anteriorly and often posteriorly as well. So this is a worse prognosis than if you just have a compression fracture. So this is a burst fracture. And then if you get motion, either translation or rotation, that's even more severe, with a much higher likelihood of having neurologic changes. So that's the one way you can describe it to help. And then you can have a distraction lesion, which is the worst overall, where you tend to also then get injury to the posterior elements. And these have a very high incidence of associated neurologic injury. So in this, an important thing is the posterior ligamentous complex, the PLC, which again is the spinous processes, these ligament and the interspinous ligaments here. And when you have, if you have a simple compression fracture, the posterior elements are almost, or kind of by definition, still intact. If you have a burst or burst lesions, it may be involved. Distraction lesions you're going to have involving the posterior cortex. So you need, the posterior elements. So you need to evaluate the posterior ligamentous complex, the spinous processes, and the ligaments here. And then if there's a question of an injury, it's a 2. If it's definite injury, you're increasing the risk by adding a 3. And then you can look at the neurologic status, which we typically don't do in a radiology department. And then if you add these up, 0 to 3 is non-surgical, 4 is in between, 5 or greater, generally the patient's going to go to surgery. And this is just a kind of a checklist you can go through the different elements that need to be described in the report in these acute injuries. Okay, so let's start here. I don't know who's next.
It's me.
Okay.
T1, T2,
I'm sorry, John, you said something?
No.
Okay, go ahead.
So
Dan?
T1 and T2.
Yeah, T1 and T2 is a low field, old images.
So it looks like there's a compression fracture at some mid-thoracic level.
Okay. Yeah, now what we see here are 2 different ages. Here's an old compression fracture, and this has probably is a variant anatomy here. So because we don't see much edema and the lower vertebral body that's involved, we see acute type edema up above. So this is probably a chronic lesion. and this is as an acute fracture. And there may be some acute components here, but my guess is that there are two different ages of these fractures. At this level, the posterior cortex is intact. At this level, you have a little buckling of the posterior cortex there. And it looks like, you know, the height is decreased both anteriorly here, which is not too uncommon. So this is probably an old compression fracture, which might have a little bit burst component to it, but it's probably an older compression fracture. Here, I would be very concerned that this is more, because I think we're actually getting compression in both the anterior and posterior cortices. So this would be kind of in between a compression fracture and a burst type fracture. So, and then obviously you'd have to evaluate the posterior elements, because that PLC complex is very important for prognosis. So I guess we call these compression fractures. Okay. Elior.
Right, so that, looking at that vertebral body, let's see, 5, 4, 3, L2, we see, looks like a fracture line and surrounding edema.
Right.
So just a compression
Yeah,
fracture.
it's probably a compression fracture. Now you notice here that that posterior cortex is a little bit abnormal here.
Mhm.
And the main reason that whenever you see these to evaluate that posterior cortex, because if you get a lot of bowing of it, that's a very poor prognostic factor that's commonly associated with malignancy. Here, this is very subtle. And what we see here is that the fracture line is very sharp. If you had almost always when you have a pathologic fracture due to tumor involvement, you'll get bowing of the posterior cortex, which is more prominent than we see here. And you won't see these fracture lines as sharply because you have infiltration among all of the trabecular bone here, and you get less sharp delineation. So this was treated as just a compression fracture. So it's treated conservatively.
Would you watch it?
I wouldn't redo imaging unless the patient's clinical course was unexpectedly got worse.
You know, as a clinician, I think I'd have the patient come back in a month or so and
Yeah.
keep checking. It may be completely just a compression fracture, but the bulge always bothers me.
Good.
All right, 85-year-old female, back pain after a fall. Here it looks like we have a very severe compression fracture, probably with some retropulsion of the fracture posteriorly, right?
Well, I think is what we're seeing here. We're at the level where we're seeing part of the pedicle here,
Okay.
and we're seeing edema going into the pedicle. We got marked compression anteriorly and centrally, and we can see the fracture lines very nice and sharp here. So this is 32911. This just shows that we have some edema going into the soft tissues.
Okay.
You always want to evaluate the soft tissues. If it's tumor, you'll often get tumor infiltrate around when you have acute fracture, you can get hemorrhage around it, which can also, if you're not careful, masquerade as a tumor. So you have to be careful. But again, here we can see the cortical margins are nicely intact. So this was just osteoporotic. Now this is 9/17/03. Everybody waiting with bated breath? Oh, it didn't come up. There we go. What's that? Hold it.
What?
Oh, no. This is before.
Oh, yeah. Okay.
So that's what it looked like before. Yeah, just to prove to you that
Thought it was a miracle.
at one time it was
That's good, sir.
intact. So that just shows. So that was a acute compression fracture, and it was just hemorrhage around it. Okay, Robert.
All right, August 2007. So it looks like we have some anterolacesis of L5 on S1. Don't see an acute traumatic abnormality otherwise.
So I just want you to look at the L4 vertebral body. So this is August, and actually this was imaged because the patient was having back pain after a fall. And then the back pain got worse a month later. And this is what it looked like a month later without any history of trauma between the two.
So yeah, now it looks like there's a compression fracture. There's pretty significant height loss.
Yeah.
Progressive disease.
Yeah. And then here we can see that there's actually loss of height, both anterior posteriorly as well as markedly in the center, some sharply defined hemorrhagic component to this. And this was an acute osteoporotic compression fracture, just to see what it looks like.
It still doesn't bulge posteriorly, does it?
No, it's not bulging. It decreased height, but it's actually not bulging.
With all that compression, you would think it would do that, but it doesn't.
Yeah, but this is typical of osteoporotic type compression
Yeah.
fractures. Yeah, as opposed to tumors and I don't know.
The posterior longitudinal ligament is pretty strong.
Yeah. I don't know if we'll get around to tumors of the spine this year or not. Okay, Dan.
72-year-old with right thigh pain weakness immediately following kyphoplasty. So looks like CT axial sagittal. Looks like, you know, we've got this compression fracture with bony retropulsion and also some retropulsion to cement into the
Right.
extradural space.
So that was cement extrusion. Good.
Okay, 82. Mhm.
So they're looking for a root impingement.
Okay. So 82-year-old male. Let's see. Yeah, so we've had surgery in the spine. Looks like laminectomies, posterior fusion, hardware on the left. I'm not sure. Let's see. Is there a fracture line in that vertebral body on the left there? Yeah. Sagittal, yeah. I'm not sure if I think I'm
And
seeing
then
it.
some central stenosis here.
Yeah.
Yeah. Good. Okay. All right, Jason.
All right, 72-year-old male, status post-fall, rule out fracture. T11 looks like there's a loss of the normal fat signal and decrease height, collapse of that superior end plate, right? But then there's also some going on in the posterior elements too. That's causing a lot of canal stenosis there in that middle image.
So if you ask me what I thought the mechanism of this would be, I would say it's somebody who was in an automobile accident who had a lap belt on. That's the classic way this fracture occurs, and it's called a chance fracture. Yeah, but you can see that these can be unstable because the posterior ligamentous complex is disrupted here. So this has a potential of being a much more unstable lesion than the others we've looked at. And already we have central stenosis with probably compression of the cord in this location. So
I think that goes with the seat belts.
yeah, this looks like a seatbelt fracture. Okay.
All right. We have a 48-year-old female with CT scan performed to evaluate abnormal chest X-ray findings. And
So that's the AP. I don't know.
yeah, some increased linear density there, right hilum region.
Okay.
So she's
Negative CT 1 year ago, recent vertebroplasty followed by surgery. You can see the surgical changes down here. So what do you think might be happening here?
Is that maybe some cement that's
Yeah, that's
embolized to the pulmonary arteries?
there's the CT.
Yeah, so it's definitely some, yeah, embolus.
Good.
Oh.
Dan?
Vertebral male trauma. Built with the reach of the body. There is, looks like there's a loss of cortical integrity of the anterior and posterior.
Yeah, so you've got a comminuted fracture. This is a burst type fracture. And I'm very concerned about what's happening here among the neuro elements.
Yeah.
And I'm also very concerned. I'd like to get a lot more imaging to look at the posterior ligamentous complex in this particular case. So this to me looks like a very unstable, high-risk lesion. And then if we do further imaging,
Paraplegia.
right, exactly. So what do you see with further images?
You see extension of fracture to the right
Yeah.
posterior element.
So you got fractures both anteriorly and posteriorly. So this is a very unstable fracture with probably a lot of compromise of that central canal. You don't see any fat inside of it on the T1 weighted image. Yeah, so this is a burst fracture, and this patient had a tear of the dura. So typical, as we talked about, burst type fracture. Elior.
Okay, 47-year-old male. Okay, I see some fluid in the kind of interspinous process region. Looks like they've had surgery, got posterior fusion hardware. It's the same signal as CSF. I'd be concerned about meningocele.
Yeah.
Dural.
So this was a post-op dural tear. So this wasn't hemorrhage, but it was still fluid extravasating into the epidural space. Okay.
All right. 45-year-old male, fall down from 6M in drunk. I guess he's still drunk while he's writing that.
I think 6M means 6 meters.
6 meters, okay.
Sounds like he's shouldn't even be alive. So I don't know. It sounds like a pretty big fall.
So it looks like we have a fracture at the vertebral body and extends to the posterior elements. Yeah.
That doesn't look stable to me.
Definitely not.
So-
Yeah, looks like the
So again, we're dealing with a burst type fracture and which extends into the posterior elements. So I agree with John. It doesn't look stable to me either. And then here's what the MR scan looked like. And I'd be very worried about the neural elements right through here too. Okay. So they thought this was a burst fracture, injured the posterior ligamentous complex. We don't know what the neurologic involvement is, but so far we've got a 5, which would put it in the surgical category. Okay. And they went in and operated on that patient. So that's kind of the TLICS classification system. So the main thing that I do is just look for those different elements. I never score it here. You know, you may be in a hospital at some point where they would want you to score it, but again, most of the score requires clinical input, or some of it requires clinical input. So, is what we give them are the morphology and the posterior ligamentous complex, and they have to add the neurologic involvement and decide on whether they should go to surgery or not. And just go through this. So and that this just diagrammatically shows that I think we've already gone through all this stuff. Different kinds of fractures that we've seen here. So So again, we can see. Good. Let's see this. Okay. Here, let's see.
For me, are they stable or they're not stable? And that's what I want to know.
Okay, good. And are
And the rest is
do they impinge the neurologic?
for research.
Okay, who's next?
I believe it's me.
Okay, go for it.
All right, so here it looks like there's another compression fracture, pretty extensive height loss. I think that's L1. There's a fracture of the L2 superior end plate as well, not as extensive as a degree of height loss there. There's some focal kyphosis and then pretty severe spinal stenosis.
Yeah.
I think I'd use the term severe compression fracture.
Okay,
I don't know if they have a number for that.
right. And then I got, looks like compression of the conus here, but no, we don't see any edema or hemorrhage in the conus at this point, but definite compression. So this is almost certainly going to be a surgical case. We can see multiple levels are involved here. This is osteoporotic. So osteoporotic fractures tend to have straight posterior cortices, edema adjacent to the end plates. The posterior elements tend to be spared in osteoporotic fractures. Typically not a soft tissue mass, no restricted diffusion, which you will see in tumor. And enhancement is really not helpful in these cases. Malignant compression fractures, you'll see focal paraspinous masses, deposit-like involvement of the pedicles, no intravertebral fluid, which you'll often get with hematoma and spaces in osteoporotic fractures within the vertebral body. No other compression fractures. And malignant lesions tend to be in younger people, though they certainly can be in older people, whereas the osteoporotic fractures are almost all in older people. Dan.
77-year-old female with back pain and no acute trauma. Radiographs, lateral, AP. That's the going lower thoracic chamber. There's a compression fracture with, looks like there's some superior bone direct repulsion with a lot more images though.
Okay, so it looks a little bit like that last one that we saw. Now notice that there is this low density material in here. What's that? What's going on there?
Is that like air? So it's like maybe some osteonecrosis.
Well, I think this is an acute fracture. I don't think this is osteonecrosis. But this can be gas inside the fracture, and that it's pretty uncommon. But when you see it, it's virtually never associated with malignancy. It's almost all associated with osteoporotic fractures. There you can see the gas. And there it is on the CT scan within these. So that's considered a sign of benignancy. That's called Kummell's disease. I don't think it's osteonecrosis, but that's okay.
It's from 1891.
Right. Okay, Elior.
Okay, so history of back pain extending into both legs increased after chiropractic injury.
Dan, what were you doing?
Yeah, exactly right.
I see a disc, looks like a disc protrusion at maybe L4 or 5 there, yeah. Looking at the bones, those look okay. Arrow pointing to, yeah, the protrusion, and the yellow arrow to, is that Barr's defect?
Axial images.
Is this, yeah, are we just seeing the Barr's defect on the left?
And it's like kind of a central stenosis. Not great images.
And
There's a
some degeneration there, some bone
posterior element fracture.
fracture, okay.
Okay, Tayson.
All right. So looks like at L4, the anterior aspect of the superior end plate is depressed. I don't know.
This is an Ant Mini.
Is it?
So this is called a limbus vertebra. These are thought to be due to lack of fusion of the growth plate, the circumferential growth plate there, and are kind of considered, quote, normal variants. I'm not as confident that these are actually normal variants and that these may actually be old fractures, but they tend to be stable and they tend not to be associated with definite symptoms and are not surgical lesions. John, you want to say something?
I remember hearing people say that this was a congenital entity.
Yeah.
But I think that this is more of a fracture from years ago.
Yeah, and I agree with you. All righty. I forgot who's next.
I think it's me again.
Okay, great.
All right.
Poor Robert. He's stuck out in the wilderness area and forgotten about.
No worries. Here it looks like there's a disc extrusion posteriorly. What's that? L4-5 extends inferiorly there.
What's going on there?
Ooh, oh yeah. Looks like there's some edema in that. Was that the interspinous ligament?
Yeah.
So I'd be concerned about a tear that there. Yeah, there's some fluid there for sure.
Yeah. So this has a disc extrusion and an interspinous ligament tear. And here's a chronic degenerative interspinous ligament tear as opposed to acute traumatic one. And you can see here that this is associated with a cyst associated with a ligament tear, which is compressing the thecal sac. And then here are these degenerative cysts that can come out of degenerative injuries to the interspinous ligament, and they can produce mass effect upon the cauda equina. And they're typically in degenerated spines, so it's not uncommon to have a degenerative disc protrusion associated with them, but they can cause together significant central stenosis. Okay, Dan?
14-year-old man, after 30 minutes playing basketball 4 days ago, develops back pain, fever, and headache. Elevated CRP, SR, mildly elevated temperature. L-spine, no fracture. Especially spinous process is identified. All right, let's see what that looks like. Oh, so pain after there's like a lot of increased signal in the posterior element soft tissues, spinous process area. That is the.
This is why we got rid of our basketball court so the fellows wouldn't injure themselves.
How many have increased temperature? Okay, so
That's post enhancement.
some kind of
So what do you think is going on here?
some kind of like minus. I don't think it's a. Oh, this be like I'm like it's a teenager, it's a young person. Did you have to?
Yeah, look at it.
Well,
It's very well. Good muscular development there.
Okay.
So this is an athlete. It's an athletic injury. And these are interspinous ligament and muscle tears of the, like we kind of started the lecture on.
A 68-year-old female, tender posterior mass. Yeah, in the posterior elements, we see as a skin marker underlying edema in the interspinous processes.
Interspinous ligaments.
Yes, those look discontinuous.
And then we don't have a pre, so we don't know whether this is enhancement or not. So, but we can.
Yeah, could this be ligament tears or, okay.
And these are chronic degenerative tears of the ligament here, and it's really considered a degenerative disease. You can see all the subchondrocystic changes in eburnation of the adjacent bones, and these are degenerative tears, and it's called Baastrup's disease. When you get a hypertrophic bone like this, degenerative disease, and it can be very what?
I was gonna say, I thought like on the X-rays that we, usually learn about, they're all kind of articulating with each other, right?
Yeah.
Yeah. Processes.
Yeah. Yeah, they can kind of hypertrophy. What happens is when you get older, you start dehydrating your discs. The volume of the disc decreases. You then usually get degenerative tears and so forth. But over time, what happens then is that the disc kind of heal the tears and the extrusions and the protrusions and so forth as you get in middle age, and you end up with degenerated discs and a collapse of the disc, loss of the height. You lose height. Most people my age are an inch or two shorter than they were earlier, just 20 years earlier, due to the loss of the disc height here. And with that, you start getting decreased space between the spinous processes. You get degeneration of the interspinous process ligaments because you get grinding of the ligament basically between the bones. And then you get these degenerative disease of the bones because you have direct articulation when you shouldn't. They should be separated, but they're not because you've lost height from the disc disease. So it's a pain in the ass to get old.
Robert, are you taller in the morning or at night?
I believe in the morning.
You're right. What approximately is the difference?
Ooh, that's a good question. Maybe a centimeter or two?
No, it's about half an inch.
Yeah.
Now, when you see these people at this age, for ankylosing spondylitis, obviously that they don't get any difference. But the stresses are there. Now, this patient gets stressed, especially with degenerative disease. So this patient's height, and when they get up and walk, they're probably putting stress on that area and keep inflaming it. I think the cortisone injection occasionally was very helpful.
Okay. Who's next?
I could go. I don't know who's next.
Wait, Robert, did you have the last one?
I think we forgot. Yeah.
Go ahead, Elliot.
Yeah.
Hey, I've got an excuse. I'm old. You guys are young. You have absolutely no excuse.
Bone scan. Increased uptake in a lumbar vertebra.
Okay, area.
Yeah.
Maybe the disc. Who knows? This is what the MR scan looks like.
Yeah. Some edema between the interspinous processes. Looks like they're articulating.
So the vertebral bodies are okay. It's really coming from the posterior elements.
Yeah.
And you can see all the edema and degenerative disease, eburnation, bony irregularity. And again, and here we can see a lot of edema that's surrounding the spinous processes, and right where we're seeing this, and this is another case of Baastrup's disease. And just remember that when we see sclerosis, it's most of the time it's not symptomatic. Edema, on the other hand, is more likely to be symptomatic. Okay, Jason.
All right. Left side. So in the paraspinal soft tissue, there's some increased signal. Right side there looks like some increased signal interspinous ligaments. It's been on 4, 5, and on 3, 4.
Yeah. So what is this?
Um,
Not fancy. This is just a tear of the multifidus muscles.
okay.
So why don't we stop here and we'll pick up this fascinating discussion next week.
Okay.
Have a good weekend, everybody.
Thanks, John.
Thank you. You too.
Thank you.
Take care.